Yes, yes.
Can Ajay sir start his presentation?
Informed consent for vaginal delivery. A very important topic, and many a time so many of our gynecologists spend in their mind. Is consent needed for vaginal delivery? Always yes. Because when we go with any consent, usually we go with two parts. One part is information and second part is undertaking on part of patient and relative. Because if consent is not taken and something goes wrong, then it becomes a medical legal issue, and many a times it becomes difficult to face in court of law. So it is very much needed, and in India, consent is always real and valid. In foreign countries, it is informed consent, but in India, real and valid consent, in that informed consent is a part of that. So when we go with any consent, and famous case of Samira Kohli versus Prabha Manchanda decided in 2008 in India, it has a landmark case, because in Indian context, what should be the ideal consent, what should be the real consent was discussed at length in that particular case. And in that particular case, it was decided that patient should have all the information of your treatment plan, which treatment you are going to offer, or any surgery or any procedure you are going to offer, should have knowledge to the patient, and with all its benefits and its side effects. Of course, very remote complication we need not to tell, but major complication we should tell. So as far as vaginal delivery is concerned, we are under obligation to inform patient and a relative with the patient to how our plan of delivery is, with an induction of labor or acceleration of labor, with episiotomy, without episiotomy, a possibility of tear, any degree of possibility of tear. It could be third degree or sphincter injury also. Need of instrumental delivery or any operative delivery. So we have to explain everything to the patient whenever we are planning vaginal delivery. But I think Dr. Ajay is the master person.
Yes, sir.
Because
we have Dr.
Yes,
Ajay's views,
yes,
because
yes.
Thank you.
So over to you, Ajay.
Yes, sir, please.
We've got Dr. Ajay Rane, who is professor from all the way from James Cook's University, and we're going to get a nice complete overview of informed consent for vaginal delivery, as he's a well versatile doctor with a lot of knowledge. Dr. Professor Ajay Rane, please.
Thank you. Namaste. Thank you so much for the kind invitation. Laxmi, I just managed to skip the urological conference and come over to you. I have got 22 minutes, so I need to be on time. I think the important part for everybody to understand is, so far, I know that every single obstetrician takes a 2-page consent for a cesarean section. You talk about risk of anesthetic, you talk about infection, hemorrhage, hematoma, DVT, all sorts of things. But I don't think there is a piece of paper that actually looks at a consent for vaginal delivery. So it is very interesting. The issue really is a bit more complicated. And I know that MC Patel Bhai is very good medical legally, and he made some very valid comments. So we are going to go through this journey slowly so that we try and understand what we are talking about, okay? So we can start by, why is my screen, oh, hang on. My PowerPoint is not working. So 1 second, let me go back to my screen share. See if this works. No, okay, so try the other one. Sometimes these things are quite funny. You can see my screen, right?
Yeah, we can see.
Yes, we can see, sir.
Let's make it slideshow.
Yeah, make a slideshow now. Yes, it is working. working finally, thank God. Okay, so I think the important part to understand is a medical practitioner has a legal duty to warn a patient of a material risk inherent in a proposed treatment. If you believe vaginal delivery is a proposed treatment, failure to do so might be a breach of the practitioner's duty of care. Okay? Patients have a right to refuse treatment, but this exercise of choice can only be undertaken when the risks are adequately explored, meaning that the patient has been given adequate information about the pros and cons of each proposed treatment, be it a vaginal birth, be it a cesarean section. Failure to give that adequate information will lead to a breach of duty of care by the practitioner. I think that is the first basic concept you need to understand. Obstetric care, however, is very unique regarding its medical and social expectations. Vaginal birth is traditionally viewed as a natural process, as the de facto fallback position, and any alteration of that process is only deemed as an intervention. So there are two patients, mother and baby, and maternal preference may not be in the best interest of the fetus, but the fetus has no legal rights until it is born. Thus, the physician's primary responsibility remains with the mother. For example, if there is a risk of an actual baby dying, but the mother refuses an intervention, at that time, the physician's primary responsibility remains with the mother, irrespective of the outcome of the baby. But as soon as the baby is born, it has legal rights. So you need to be very careful about that understanding. So there are legal concerns and there are changing outcomes. So we need to really look at how we are doing obstetric care. So we'll go to the UK first because they were the bravest people and probably one of the most outspoken people about normalizing vaginal birth. So the review of the Shrewsbury and Telford Trust review said there was a culture of keeping cesarean sections low because this was perceived as the essence of good maternity care, without consideration of whether this culture contributed to unnecessary harm. So if you want to read this whole review, it's a very interesting review, a lot of maternal deaths, a lot of neonatal deaths, because there was this culture that we have to keep the cesarean section low, otherwise we're not performing good maternity care. So I think it's very interesting in 2020 to understand this review, Shrewsbury and Telford Trust review. There is a lot of now news in the media. We have the Australian Birth Trauma Association. So it feels like a violation of my rights, mother is saying. Mothers are not being given the right to choose, the right to consent to a modality of birth. And you can only consent a woman to a modality of birth if you give her adequate information. The number of legal cases involving the consenting process during vaginal deliveries or lack thereof have doubled in the world over the past 5 years. So what are we seeing here? We are seeing that it's not the question about whether the delivery was conducted properly or not. It's a question of giving the information to the patient and the consenting process during the delivery. That is the issue. It's not a question of whether the delivery was done properly or not. There may be an overarching trend whereby women are no longer prepared to silently accept potentially avoidable risks that they were either unaware of or felt coerced to endure Now, one of the things that you probably don't have, fortunately, is a very strong midwifery group, because sometimes we believe that women are coerced to endure potentially avoidable risks under the guise of normality. So I think it is very important to understand, so far what we are trying to say is, it's not a question of vaginal birth or cesarean section. It's a question of giving equal information for both. Because at this moment in time, it's very biased, lots and lots of pages for cesarean section consent, nothing for vaginal delivery, okay? So cesarean section rates have definitely risen from 17.6% to 30.5% in Australia. But there are changing factors affecting obstetric outcomes. One of them is aging maternal population. Our women are not having babies at 19, 20, 21, 22. The average age of first childbirth in Australia is 33. And in India, I am sure in the educated class, they are deferring to have babies because they need to have a career, they need to get their postings, they need to have success in what they are doing, and then they are looking at childbearing. Nothing wrong with it. This is what the modern world is. The second problem, however, is increasing BMI. 17% of our primates booking in are more than 125 kilos. Now, I don't think there is anything natural about a vaginal delivery in such patients. Both the aging maternal population, we have now shown scientifically, has a much stiffer tissue, so tissues don't stretch very well. And increasing BMI makes obstetric outcomes definitely challenging with vaginal birth. So I think the so-called natural process we were talking about had some optimum parameters around it. Those parameters have changed. Therefore, natural vaginal delivery, normal vaginal delivery are terminologies that you will see in the next slide that are actually being given up. So in Australia, we have the Australian Commission of Safety and Quality in Healthcare, and they have shown data that in Australia, the rate of severe perineal trauma is above the reported average in similar OECD countries. What you're really trying to say here is, we went through a phase of what was called normalization of vaginal birth. Everything should be vaginal, everything should be vaginal, everything should be vaginal. And then when we started looking at the data of severe perineal trauma, it certainly was something that was much higher than what was anticipated or compared to other similar countries. We are not even going to talk about pelvic organ prolapse, urinary incontinence, sexual dysfunction, anal sphincter injury, because these are unique risks associated with vaginal delivery, but they are delayed risks, where even if we just stay with the tangible, immediate risks of perineal trauma, you still need a lot of information given to women when they are contemplating a vaginal birth. So what really happened in the UK was there was a big campaign for normal birth. This was called normalizing birth in the UK. As soon as it happens in the UK, Australia adopted this campaign for normal birth. It was a document aimed to define normalcy in birth as the prevention of interventions deemed unnecessary. Basically, this was people saying, don't have syntocin on, don't have oxytocin, don't have augmentation of labor, don't have an assisted vaginal delivery, don't have an episiotomy, based on what? They were largely adopted non-evidence-based recommendations. That policy had to be abandoned because this stance of passive management actually increased obstetric anal sphincter injuries. And this was published very recently by Petros and his group. So that was the first nail in the coffin of normal labor, because not a lot of information was given to the mothers. Then there is bias issues. There is lack of scientific credibility behind the push for natural birth, which impedes the consenting process of vaginal delivery. People are not giving an unbiased view. They are just giving a biased view. Negation of maternal autonomy by not offering vaginal intervention. So if you have to offer vaginal intervention as and when required. So this was the famous Montgomery case, which you should also read. And it reads very well because it says, it looks like a judgment that vaginal delivery is in some way morally preferable to a cesarean section. So much so that it justifies depriving the pregnant woman of the information needed for her to make a free choice in the matter. It's a very powerful statement by non-medical people. So what I am really trying to say here is, if the obstetricians and the medical people don't take charge of this issue, the lawyers will, the judges will, the politicians will, and we will not win in this war then. We have to take this issue, not let the politicians and the judges take the issue. So I think it's a very important lesson for us to learn. Let's look at the flip side. The flip side was, if we started consenting for vaginal deliveries and increasing maternal autonomy, would there be an increase in maternal request cesarean sections? Which basically means doing a cesarean section without any valid reason, and possible sequelae of surgical complications. So ever since we abandoned the Towards Normal Birth program in 2014, there has been a 0.003% increase in maternal request cesarean section rates, which means in essence zero. There has been no increase in maternal request cesarean section rates. What women are asking is for unbiased information, and they want to be taken with them in the journey towards childbirth. They want you to take them with you. They don't want to be told, they want to be incorporated in the discussion and the information of intervention during vaginal birth, vaginal delivery, and cesarean section. All women are asking for is a partner in the journey. They don't want to be told that this is normal, this is the only way for you. There is no other way. So I think in conclusion, recognition of mother's right to make an informed decision is paramount and defines the push for consenting patients for vaginal delivery. So I think the mother has to have a right. And I will put this very simply by saying, I talk to a mother when I say, I will not take you kicking and screaming for an elective cesarean section if you don't want to have one. But neither will I take you kicking and screaming through a vaginal birth if you don't want to have one either. There has to be a balance in what we offer to women. I think it's very important that we have an ethical and cultural shift, not just in the Australian context, away from focusing on the natural and more on the evidence base. And I'll tell you the reason why Laxmi invited me for this talk. We have just completed the world's largest study surveying obstetricians, midwives, obstetric residents, nurses, and mothers. It's a very large survey, thousands and thousands of people, going to be published hopefully in the Lancet very soon. And what it showed in a nutshell is that if you try and normalize vaginal birth, it actually leads to a delay in critical interventions to be taken during problems during vaginal birth. So if you just keep saying normally, 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 then if something goes wrong, the time that is taken for critical interventions actually reduces. And this has been an opinion of obstetricians, of midwives, of trainee registrars, and of mothers. So it is very important for us to understand that vaginal birth at all costs is not the answer. Elective cesarean section for all is not the answer. The answer is adequate, unbiased, balanced information and giving our women, including my daughter, who's 19 years old, I hope she doesn't have a baby soon, the confidence when she goes to her obstetrician that they will together be in their journey and that she will be very comfortable then in making the decision of whatever birth she wants to have. At this moment in time, I cannot put my hand on my heart and tell my daughter that she can have a vaginal birth. I would rather that she have an elective cesarean section because we are not taking our women through the journey. We are informed consent is not saying once you sign, that's what's going to happen. Informed consent means giving information, taking the mother with you on the journey. It's her journey. It's her baby. You're only a small portion in her life. So behave as one.
Start
Thank
video.
you very much.
Thank you, Dr. Ajay. Rightly said.
Dr.
This is
Dilip
not
Kumar, please,
merely.
Dr. Sarangi, please mute your audio. And Ajay, Nikhil has not stopped you, huh? Please, it was echo from somewhere. So
No,
you
no,
can
I know. No, I had finished.
I am mesmerized. I am mesmerized by your talk. And when I invited, I was really not knowing about your study. I told boss मुझे आप चाहिए मेरी कॉन्फ्रेंस के लिए पर यूरोगाइनेक नहीं सुनना है वो बहुत सीख गए हम लोग ऑब्स्टेटिक्स क्या बोल सकते हो आप and I was really amazed when he said I can speak on consent for vaginal birth. मैंने तो है ना अजय को भी लपक लिया और टॉपिक भी लपक लिया. I just carried. I said you have to be there.
I have to say,
Thank you, boss.
Thank you. This is the very hard work of my PhD student, Dr. Harsha Anantram, who's a consultant in Sydney. All this work has been done during his PhD, and it's a very, very important topic. We believe that very strongly in that, and it is really applicable to each and every single pregnant woman in the world. It doesn't rely on health literacy. It doesn't rely on health literacy.
And I think Ajay, because you are urogynecologist, I think you have done full justice to the topic because you know what urotrauma is.
Indeed, and yet we are not saying you need to have elective cesarean sections. We're absolutely denouncing that. We don't want people to be doing cesarean sections to prevent incontinence, to prevent prolapse. But we do want people to do better vaginal births, taking care of the pelvic tissue trauma, and also we want them to take the women through the journey together.
Sir, what about those patients who really don't want them to go through the pain, labor pains? And nowadays, we are seeing many patients coming forward and telling that we don't want to have all the pains and all that. You just take us directly for a cesarean.
Yes, and again, I
There's
think
another
Raki,
party.
no, look at what I'm going to say. How many children do you think such a person is going to have? Maybe one
or two.
Right? That's number one. Number two, they're probably in their mid to late 30s.
Yes.
They are used to being in control because they're executives. They're used to ordering everybody, including their husbands. These
Yes.
are women who are constantly and totally in control, right? And once that sperm goes in and fertilizes the egg, it is completely out of control. Their
Yes.
bodies are swelling. Their whole attitude is changing. They're unable to walk properly. They're unable to sleep properly. They lose control. They want their control back. Such women also should be taken through the journey. Believe me, Raki, if you take them through the journey, you will arrive at the right position. I am not saying that you say, yes, habar tera Caesar kar denge. Or the other way, kya bakwas kar rahi hai? Sari duniya vaginal birth kar rahi hai, tu kyo Caesar tu kya special hai? I think the important part is the journey, is the communication, is the taking people through it. And I think if you take those people who are actually asking for elective maternal cesarean section, will be less than 3%. But you will be spending 80% of your consultation time with them, because these are the difficult patients.
Difficult patients.
Right? So you need to even put more effort with the journey. Take them through the journey and you will be blessed, because the decision will be a combined decision. There is a simple dictum. I talk, you talk. I talk, you talk. I listen, we decide.
So thank you.
I talk, you talk. I talk, you talk. I listen, we decide. There you go.
So thank you, Ajay. Rightly said, it should be informed one, and I will share only in 1 minute. There was one famous case of C. Jaipal Reddy versus Dr. Padmini Velluri, in which National Commission has pointed out that consent is not mere a piece of paper where patient signs.
Yes.
It is documentation of your communication, documentation of your counseling, giving information about the treatment plan or any procedure or any surgery you are going to go for. And one more thing for information, we are on FOXY level preparing for uniform consent. And for the interest of all the delegates, I myself have prepared consent for vaginal delivery. And it will we are going to submit all our consent we have prepared to FOXY within very few days. And then it will be available on FOXY website for all our FOXYan friends. And we are going to publish almost 100 plus different consent for different procedures. But just now we are ready with almost 30 or so. So this is for information only. So congratulations and thank you, Ajay.
और अजय बॉस जाते जाते चैट बॉक्स में आपका वो रिवायत का ये डालो लिंक डालना फ्रेंड्स और another common passion between me and Ajay apart from urogynecology is our passion towards female feticide, and I must tell you all that we have produced a film on female feticide called Rewire. It is available freely on the net. बॉस जरा चैट बॉक्स में डालते हुए जाना.
I will do that. Thank you.
Yes,
thank you,
and really his passion for women's health is commendable, Ajay. Hats off to you.
Thank you so
Thank
much.
you,
Thank
sir.
you. Thank you.
Thank
Thank
you,
you,
sir.
Rocky. Always good to see you. And Rubina as well. I miss my days in Figo, but it's lovely to catch up. Sunita, I see you're enjoying yourself somewhere nicely. So thank you all so much. Thank you for giving me this opportunity to talk about something that you're not used to hearing from me. And I hope I've done some justice, but really the main thanks goes to MC Bhai and of course my PhD student, Harsha Anantram. So God bless you all, and the chat box. Thank you again. Take care.
And I think Dr. Ajay sir, with your permission, I believe after 7 o'clock today, maybe we will be able to show this movie that Dr. Laxmi was talking about after the conference. Am I okay? I mean, I think we can do that, Dr. Laxmi. Am I right?
Yes, yes.
And also,
it's free on YouTube. It's totally free on YouTube.
Yes, it is totally
just go
free.
RIWAYAT, Rewire,
yes,
on YouTube, and it's 1 hour 54 minutes. Just for those really dardi Hindi movie goers. The last song ever sung by Jagjit Singh was in this movie. So it's a very, very touching moment. He sang his very last song before.